Rehabilitation at Johns Hopkins. I'm actually a psychologist, so I'm going to talk about some of those issues in TM this morning. But first, I want to say it's a real pleasure to be here and be part of this exchange between clinicians and consumers. It's really been, over the past 2 days, I've observed presenters trying to get their points across to their colleagues and to people with TM, and people with TM challenging the presenters to bring something useful to the fore and say, tell us something useful here. And that, I think, is not something you usually see at symposia that I attend. And I think that's a really unique and special part of this meeting, and I really congratulate Doug and all of you all for making that happen. It's an extraordinary event in science and in medicine, I think, and it's just spectacular. It's a pleasure to be here. I'd like to spend a few minutes talk, it says. Okay, good. Follow the signs. I'd spend a few minutes with you sharing some of my thoughts and ideas regarding the work that we all do as people working with TM. We're often so busy doing our day-to-day work that we don't stop and think about what we're doing and how we approach that work. So that's what I want to talk about a little bit this morning. What I want to talk about is I want to differentiate between the acute and long-term phases of TM. I want to recognize the work that is being done in TM, understand who's doing that work, hopefully pass along a few ideas or tips that might enhance the effectiveness of clinicians and patients who are doing that work, and finally challenge us all to expand the goals of treatment to include individual well-being. And we'll talk a little more what I mean by that. First, as you all know, the course of TM is marked by both acute and long-term phases. And anybody who works in medicine or has a chronic condition understands that it's a progression of activity that goes on. That each of these periods has specific goals, specific demands, tasks, and critical factors that make that period either a success relatively or relatively a failure. And we'll talk about those in a minute. What I want to emphasize this morning, and we'll talk in detail about this, is that different models of care and different attitudes and different behaviors are useful at different points in the process of TM. And that each of us have different roles at different points in this progression of life. And we're going to talk in detail about all of these. But let's talk a little bit about what I mean here. Let's first look at what I'm calling the acute model, or the acute phase of TM. And most of us know this because even before you had TM or you know somebody who had TM, we're all familiar with acute illnesses. And the best example here would be a broken bone, right? The purpose, the goal of the treatment is to do what? Cure it. Fix the problem, take it totally away. It's a very short-term situation, right? Physical factors are key. In the issue of a broken bone is you get an x-ray, you get a diagnosis, you get a cast put on it, you wait for the cast to come off, you take the cast off, you probably don't get any physical therapy, you go about your business. In TM, in the acute phases, physical factors are key here too. You need to get an accurate diagnosis, which as you all know isn't always easy to get. And second of all, you need to get adequate treatment, control the inflammation, primarily at this point. But this process is clinician-driven. Generally, if I break my arm, I drive up to the ER, I get out of the car, and I put myself in the hands of the physicians, right? They diagnose me, they treat me, I go home, I lay in bed, I go back to the doctor, bzzz, the cast comes off, go your way. What did I do? Not much, except wait around. It's a clinician-driven process, and that's true in the beginning phases of TM too. You know, when you get diagnosed with a new condition, you don't know what to do, so you put yourself in the hands of the physicians, the therapist, you do what they tell you to do. They drive the process, they set the agenda. It's a very limited focus. Fix the biology. Get the biology back to normal, whatever that was. And this is pretty familiar, and all of us know this model. Anybody who's had an earache, anybody who's had a child with an earache, a broken arm, we all know the acute model. But unfortunately in TM, for many, many people, and probably for most of the people in this room who have TM, that model isn't sufficient. They get moved into the next phase of TM, the next phase of illness, which I call the rehabilitation, the long-term model. And here the goal is very different. The goal here is improving function. That's what our rehab people are about. The goal here is improving quality of life, improving a sense of well-being. Here the situation is long-term. Most of us have not had or haven't dealt with serious chronic conditions over their whole life. We're used to saying, oh, I can handle this for a couple of weeks. You know, the worst possible case is a couple of months. No one's thinking years. No one, we feel like we've been let down. Most of us have never had the experience of having an illness or a condition that medicine has not been able to fix. It's pretty shocking, I think. But here, the psychosocial factors become key. How much support do you have from your family? What are your financial resources? Do you get depressed? How are you able to organize people around you? What are your interpersonal skills? These things become increasingly important in the long-term model. And the focus is very broad. It's not just about fixing biology. Now it's about getting out to the store, getting back to work, going to school, making love. Much bigger picture here. And most of us, this is unfamiliar territory. Most people have not walked this road before. And that makes it very difficult. But each of these phases requires a certain kind of work. And I'm going to use this term work because I think it's very important to recognize this. In TM, there's two kinds of work that needs to be done. And Mr. Gilmer alerted us to this in the very beginning comment he made in the beginning of this conference. There's professional work, and a lot of professionals have been up here talking about the work they're doing. And that's extremely exciting and extremely important. But there also is patient and family work being done. And let's talk a little bit about that. Of course, the professionals are doing work. They're diagnosing people, they're treating people, they're consultating, they're teaching. There's indirect patient services being done. People are doing research. People are advocating in Washington. But those of us who do professional work, we have a pretty developed team. I know where to get a neurologist. I know where to get a physical therapist. I know where to get a psychiatrist. I know where to get a recreational therapist. I know where to get all those people. They're sitting in offices right around my building. And the environment is supportive. Everybody's saying, yes, work together, work together, work together. And we're all pretty well trained. We're fairly well recognized, some of us more than others. And we're moderately well paid. But our commitment is limited. I think we work pretty hard, but even the dean at Hopkins doesn't expect us to work more than 60 hours a week. So we put in a full 60-hour week, we call it a week, we go home. But if you're a patient, different story. Different story. Patients are doing other kinds of work that we are not doing. You have what I call direct illness-related work. You got to identify providers. You got to make appointments. You got to take the medicines. You got to follow the physical therapist. You got to do the swimming program. You got to do the walking program. You got to do the meditation program, the relaxation program. And otherwise, if you don't do all these programs, you are a bad patient. And then you got the illness-related work. You got to file insurance claims. You got to fight with the managed care company. You got to arrange transportation. You got to research accessibility. Can I get into the restaurant? Can I not get in the restaurant? Where can I park? How far away is it? You got to advocate for yourself with the doctors, with the insurance company, with the senators, with the stem cell people. And then you got to also research treatment options to make sure the guy you're working with isn't missing half of the boat. And then you got to do what I call the personal work of illness. You have to reconstitute who you are. You are not the same person. This illness takes place in the context of somebody's life. A person who has goals, plans, objectives, and all of a sudden that all has to be reappraised. And you have to do what I consider to be the most difficult psychological process. You have to resolve the issue of, on one hand, as Cody said last night, I am exactly the same person I was before. And on the other hand, my life is totally different. Now you make sense of that. What is that about? But you have to somehow resolve that paradox, either on your own, with the help of your family, with professional help. Otherwise, you will not be successful. And then there is the everyday life work you have to do. You still have to get up, take a shower, get dressed, get food on the table, get the house cleaned, and all this takes about twice as long as it did before. We did a little study a couple years ago working with spinal cord injury people. And this is it's an informal study we did. We did it in rheumatoid arthritis too, but I'm going to show you the SCI study because it's more relevant to you all. We studied 14 people who had incomplete and complete paraplegia. It was 7 incomplete and 7 complete paraplegics, okay? And we had them record for us on diaries the work they did relative to their illness. And so what you see here is they spent an hour a week in doing appointments, an hour a week doing medication stuff, other kind of treatment. They spent 14 hours a week doing range of motion, strengthening activities. These people were all about 6 months out from their injury. So they're out of the acute phase, but not 10 years down the road. They're spending about 2 hours a day doing range of motion, strengthening exercises, programs. They spend about an hour a week working on insurance issues, which I think is underestimation. They spend about 2 hours a week trying to educate themselves, surfing the net, reading magazines, talking to other people on the phone. They spend about 2 hours a week doing what I call personal work. This is formal personal work, either in psychotherapy, doing support groups, or praying. But they estimate it takes an additional 2 hours a day to do the stuff they used to do before. Get dressed, shower, shave, get to where they want to get to. And an extra 3 hours a week arranging what I call developing systems, figuring out how am I going to get there, arranging transportation, working out problems with school, with work. So these people on average spent 38 hours a week working on their illness. They haven't done anything else yet. They have not gone to work, gone to school, done homework, made $1. And I don't think this is an overestimate. Is that a line? Am I way high? I'm way low. Low at best. These are we're not talking about quadriplegics here. We're talking about paraplegics, complete and incomplete. This is a 38-hour thing. This is a full-time job. As I tell patients that I work with, this is why people with on disability get paid. They get paid very poorly for a lot of work. Because in my mind, if you are fully on full disability, SSI or whatever, what you're being paid for is to do what? You are being paid, what we're saying to you is, your full-time job is taking care of your health. And we fight people tooth and nail over paying them a pittance to do a full-time job. And most of us here don't think about this very often. Particularly those who are clinicians. You might be thinking about it every day. But we don't think about this. I don't think people think about it as work. There is a lot of work to accomplish here. But most of this work is what? It's invisible. If it's invisible, it's not valued. If you don't value it, it's not work. It's invisible work that goes on that patients are doing every day. If you're a patient, though, you don't have an existing team like I have or Dr. Kerr has. I mean, we have a team. It's all set up. I know who the good people are. You don't know this. You got to put your own team together The environment doesn't support you to do this. And so what I say, that patient work is untrained. No one teaches you to do this. You've got to figure it out on your own. It's unacknowledged. No one says, boy, you're really working hard, and it's unpaid. This is something that we really need to be fully aware of all the time. And the commitment is unlimited. I'm reminded of the story of the chicken and the pig who were good friends, and they wanted to have a party. Well, they figured out the guest list very quickly. And they figured out that a brunch would be just lovely, a lovely brunch. But when it came to the menu, and they contemplated serving up eggs and ham, they realized the commitment of the chicken wasn't nearly as big as the commitment of the pig to this little party. And the same thing is true of the little party we're having here. I mean, we're pretty dedicated. We work 60 hours a week. But you're working, as they say in the Hopkins thing, what? 24/7, 365. I go home at 6 or 7 o'clock at night. If you have TM, you go home, you still got TM. You're still doing that work. It's very easy for clinicians, I think, to think that patients are working the same schedule they're working. That at 7 o'clock, we all call it quits, shut the diseases down for the day, and go on home and call it as an emergency, we'll deal with it. Not that we're bad people or we're negligent people, it's just, it makes sense. I'm going home, you must be going home too. Out of sight, out of mind. The question is, how do we assist you all in doing what I call the central work? Because the patients actually are the central workers. I think the first thing the clinicians need to do is we need to recognize this stuff, because that dignifies the work being done and it gives respect where it's due. The respect tends to flow uphill when in fact towards the doctors, when in fact it should be flowing from clinicians to patients. The second thing we need to do is spend a lot more time teaching people how to manage their illness, or how to manage their disease, how to manage the system, how to get things done. And we need to acknowledge the fact that patients and families are the team leaders. We work for you. And if you have physicians or therapists or psychologists who are working with you who don't understand that, they need a big dope slap, as the Myelitis brothers say on Car Talk. They're working for you. You're paying their bills. They are not paying your bills. They're not doing you a favor by seeing you. You're doing a favor by seeing them. And we're sort of out of kilter with this whole situation. And we need to focus on the goals of families and patients. You know, when we're doing rheumatoid arthritis work, we kept asking the patient, rheumatologist, what's the most important thing you want to know? I want to know the patient's SED rate, the sedimentation rate, which tells you inflammation. Patients don't care about SED rate. What do patients care about? Pain. The clinicians are looking at the SED rate. The patients are talking about pain. They're related, of course, but not one-to-one. Let's talk about how you become a more effective worker. And Mr. Gilmer pointed out a number of really important ideas about how to be an effective worker. And I really encourage you to go back and read the beginning portion of handouts that he had at the beginning of the book. But first of all, you need to recognize that you're responsible. Not the physicians, not the therapist. You're the one who is responsible. It's your life. You're the one in charge. The second thing is spend time getting educated. Of course, I'm preaching to the choir here. You all are here. We're talking to the wrong people. But we need to get people with illnesses and TM and other kinds of chronic conditions educated so they're better workers. Develop yourself a team and lead them. Teach them what you want to know. Teach them about you and what's important to you. What's important to me as a person with TM may be different to somebody else with TM. For one person, the most important thing is getting their pain under control. For somebody else, the most important thing is getting back to work. For somebody else, the most important thing is getting their sexuality together. Teach them what's important to you. And like all good businesses, you have to maintain records. Everybody here, or if you have a chronic condition, you ought to have a file, a notebook, a journal, where you maintain a timeline of your illness, when it started and the different things you've done over time, who your providers are, what your symptoms are, what your current medication lists are, what the side effects are. You come into a meeting with that kind of agenda, you're going to make something happen. You ought to have a good sense of what your short-term goals are and your long-term goals. If you think about this as work, you're running a business. You're running a very, very expensive business with very limited resources. So you need to know, what do you want to accomplish in the short run? The short run, what I want to do is I want to get my pain under control, for example. In the long run, what I want to do is I want to be able to get back to school or take a class or get back to work or whatever it might be. Short-term, long-term goals. And the other piece of work you need to do is you need to advocate for supportive systems of care. You need to fight the fight that we all have to fight. You need to fight with insurance companies. You need to fight, which is a fight we're winning, by the way. Does anybody know that we're winning the fight with insurance companies? Can you all tell? The pendulum has changed. It's shifted. It's shifted. It's shifted. We're winning that fight. You know, it's slow. Congress is about 5 years behind us, but we're winning. It's turning. But you need to advocate for supportive systems of care. And that ranges all the way from fighting for the patient's Bill of Rights to fighting for stem cell work. So, you go to consult with your clinician, with your physician. What do you want to have ready to go? You want to prepare for the visit. You want to know what you want to accomplish. If you don't know what you want out of the visit, cancel it. Why are you going? You need to know what you want out of that. You ought to have a goal. Focus on key issues. Preferably writing out your questions in advance. Make a list of your refills so you can just drop that to the person, all written out, so they know what you need. You don't spend a lot of time talking about that. If you go routinely to this person, get your test done ahead of time. So that way, when you get to the visit, you're able to say, what's the blood work say? To go see a person, talk, say, well, we need to find this, find this, find this, find this. They said, okay, now go to the lab. Then the results come back to the clinician, and you're like maybe in another state by now. Well, a good person, of course, is going to call you and talk about that, but it's much better to have that in advance. It pushes the process forward. Now, sometimes you don't know what's to be done, of course, but if you get routine work done, get it done in advance. If you're a clinician in the audience, we need to keep our heads together on this too. Of course, you know, the person sitting in front of us, if you're a clinician, they're one of many patients. But it's easy to forget that this individual's only life. You know, I think in TM in some ways we have a little bit of advantage because the disease and the condition is fortunately infrequent enough you don't become one of 50 people or being seen that day with rheumatoid arthritis, which is a very unfortunately common illness. You know, people tend to stand out if you have TM because it's somewhat unusual, which is a little bit of an advantage. But still, clinicians can fall into the thing of, you know, one person melding into the other person. If you're a clinician, you need to be listening, not talking. And I encourage clinicians who are working with people who have chronic conditions to develop a consultation model. That is, what you want to do is consult to the patient, provide them what they're looking for. And the other thing I think we need to spend more time doing as clinicians is teaching patients. Teaching them, like we are here today, a little bit each time. A couple things just about children. Although I'm not a child person, I've spent some time with this group. And I think what parents need to do for kids is model being proactive, questioning, asking questions, pushing the agenda. And as the child grows, you need to phase them into it. We haven't done a lot of work with TM, but we know in other illnesses, particularly the one I'm familiar with is rheumatoid arthritis and spinal cord injury, if you look at children with those illnesses, they tend to somewhat be overprotected, which is not surprising. They're not given the full benefit of their age and developmental status. And as a child ages, they should take on more responsibility in managing their care. And specifically, when you get to adolescents, adolescents should have the opportunity to meet with their clinicians one-on-one without any parents involved. Some time of the appointment should be spent just between the adolescent and the clinician. The internet. I have to make a comment about this because last week somebody walked into my office with a stack about that high. The internet is a great tool. All of us at work use that. This is a tool. And of course, doing the work of TM, you want to use this tool as well. But you should know that you can access a lot of information, the quality of which is extremely variable. But studies that have been done on internet healthcare information suggest that much of the information is unreliable. If people are making statements, you need to determine what kind of evidence they have for those statements. Because a lot of people are out there selling a lot of hope. And hope is a very useful thing. False hope, though, is very, very dangerous. So become an educated consumer. Know what a double-blind, randomized, controlled clinical trial is, of which we have how many, Doug? 0. There is no double-blind, randomized, controlled clinical trial in TM. So what the bottom line is, no one can prove anything about this illness other than it exists. They all are just basically ideas more or less supported. Avoid coming into your clinician's office with a pile of printouts this big saying, I want you to read this. This happened to me the other day for a person who was very active in their organization, and they had this huge pile. And I'm very interested, and I think I'm fairly sensitive. There's no way I'm going to get through this. I'm just going to take that and put it in the person's chart, and it's going to become a chart that's going from this big to this big. I'm not going to throw it away, but it's going to get this big. If you have an idea, distill it down, research it, and present it in a concise format. So when we recognize families and patients as the central worker, it changes everything around. People from passive recipients of care to active managers of their care. And we need to change the goals and models to include the input of patients. And recognize the fact that people with TM and their families have multiple goals. People have different agendas, and we as clinicians need to recognize that. So when we think about the goals of TM, what I want to challenge us to do is think about this a little bit differently. Certainly, one of our goals is cure and full recovery. And I think there's a lot of excitement about that going on. But we also need to keep in mind that we need to help folks improve their function who already have TM and improve the quality of their lives. And in our excitement about cure, we can't forget about what's going on with people living right today with these conditions. We just can't forget about that. And what I would say is we need to even move beyond that to think about how do people who have a condition like TM grow? How do we help them flourish? I'm getting old. I'm taking up gardening, which is a sure sign I'm getting old. And to grow a good garden, you just don't pull the weeds. That doesn't do it. Just killing the pathology doesn't fix the problem. That does not grow a good garden. If I want to grow a good garden, I have to do what? I have to figure out how do I help this particular plant blossom, flourish with this particular situation. My soil is not all that great, let me tell you right now. But I need to find ways to help plants that aren't particularly great plants, not particularly great spots, flourish and bloom. And we need to be thinking about the same thing with people with chronic conditions like TM. Not a question of just, okay, we're going to try to help them. If we can't help them, that's all we can do. We're going to keep looking for a cure for the next group of people. We have to help the people that are here now flourish, grow. And so I think we need to move beyond what I call a pathology-focused healthcare model. This model is focused on problems. It's an important model, but it's not sufficient or complete because a sole focus on pathology causes us to miss variables, to miss factors that help people improve their health status, that improve healthcare outcomes. And it also, though, puts people in what I call the victim thing. You know, you go back and read old literature, it'll talk about, you know, the victims of polio. There's a classic one. People were polio victims. You know, this is not that's not a very powerful position to be in, to be a victim. It does not encourage me to fight for my rights. It encourages me to say, oh gosh, look at poor me. This is not so the pathology model can get us, it's useful in diagnosis, it's useful in treatment, it's useful in research. It's not particularly useful in helping people grow. And we see the limits of this model showing up now, even as we're making very exciting breakthroughs on the cellular level and the molecular level. People, though, are saying this is not enough. Because if you look around, the literature tells us if you try to predict, if we take people, a classic example would be spinal cord injury, because we have research in that area. We don't have research in TM yet. If you take people with spinal cord injury and you study them, and you look at what determines how satisfied they are with their life, how depressed they are, how happy they are. What you find out is the variables that we study, how severe their injury is, how many people they have in their family, how rich they are they depressed. Those variables don't explain much of the outcome. They only explain about what we call in science half the variance. 50% of what's causing people to be how they are is something else. And what I would say to you has to do with the positive things in life: spirituality, social support, hope, how I think about this problem. At the positive variables, people are getting very interested in that. That's why I think there's a huge investment in what? Alternative healthcare. We're saying pathology-based models don't have all the answers. Let's look beyond that. Let's look at herbs. Let's look at prayer. Let's look at some other things that may have some relevance in our lives. And I think we're all beginning to realize, finally, that a person's potential is not defined by their physical condition. That doesn't really define what my potential is based on what my physical abilities are. We're finally beginning to get a glimmer of that idea. So if we contrast these things, one is a germ theory based and one is human potential based. One looks at pathology, the other one looks at strengths. One looks at treating deficits, the other one looks at building strengths. One is returning to baseline functioning, the other one is enhancing functioning. In one case, you're a passive victim, in the other case, you're an active manager. Now, I'm not suggesting that we throw out the first and go with the second. What I'm suggesting is that we marry these two. That we can focus on pathology and curing pathology. At the same time, we can focus on health enhancement. This, I think, says it very, very well. Treatment is not just fixing what is broken. It's nurturing what is best. It's helping people be the best they can be, regardless of their physical condition. And we need to be thinking as clinicians about this idea more seriously. I learned this from this guy in this bar in Ireland. Oops. I still got the talk green button, so I'm going to go on and tell you this little story. So I'm in this bar in Ireland, and this guy, you can't see it very well, but if you, the rheumatologists in the crowd out there are, and you can look at his guy's hands, and you don't forget, he has very, very enlarged knuckles. The bottom line is put the lights back on, I'm sorry, I shouldn't have called for that. He has very, very, very severe rheumatoid arthritis. Very severe rheumatoid arthritis. And so we're sitting in this pub. I'm like 3 or 4 Guinnesses into the night. This guy finds out that I work at Hopkins, that, I'm interested in rheumatoid arthritis, and I'm a psychologist, and he goes, let me tell you my story. I said, he says, if you buy me a drink, I will. So I buy him a drink, I drive him a Guinness, and he begins to tell me how he had been working on the docks for a long time in Ireland. And of course, he became to the point he couldn't work on the docks anymore. His rheumatoid arthritis became so severe he could not work on the docks. So he said, I need to find something else to do. At that time, he was about 50 years old, and he was being put on disability. But he wasn't interested in disability. He was interested in, I need to do something else with my life. Well, the guy went on to start up a little class for kids to bring them down to the dock to explain them the history of the dock and do little ecology studies in the water down there. And he had set up a wheelchair down there. And he had been doing this now for like 5 years. He said, if it hadn't been for my disease, I never would have figured out what it was I was supposed to do. Because this was a guy who was not particularly educated, and he just went to the docks like his dad did, his brothers did. But he realized, through rheumatoid arthritis, what he really should have done is what? He should have been a teacher. And the last time I talked to him, he just got a computer, and he is, in fact, still teaching at 65 on the dock, in his wheelchair now, running his experiments. But I would say he never would have found what his true calling was if it had never been through his illness. He would have gone through a whole life shuffling stuff on and off barges like a stevedore. I'm just going to skip this real quick. And come right to the point here I want to talk about. I don't mean to put rose-colored glasses on, but when we look at studies of people who have chronic conditions, and the research is recurrent on this. If you look at breast cancer, you look at spinal cord injury, if you look at stroke, look at rheumatic disease, if you talk to people who have these conditions, and some people in this audience know this because they've been in groups I've done at the hospital, is when we sit down at the hospital and say, okay, let's talk about how this condition has affected your life. And people will start saying, I've lost my independence. I need more help than I used to help. I'm not working anymore. Inevitably, what they start saying is what? They start saying, I realize people really care about me. I realize what's important to me. I realize I've been wasting a lot of time doing a lot of stuff that's not really important. And I'm going to focus my life on what's really important to me. And the technical term for this is called benefit finding. And I'm not suggesting that having a chronic illness is a positive thing, or a chronic condition is a positive thing. My point here is to emphasize the fact that people grow in adversity. That people will consistently, across different kinds of disabilities, will identify how this situation has caused them to grow in a positive way. And if you look at the kind of things people say across all these studies, they all say exactly the same thing. And I expect people in this room have had similar experiences. Not suggesting this is a good way to go about learning this. It'd be much better if we could learn these things without having adversity. But sometimes adversity teaches us certain kinds of things. And people talk about these kinds of things, about increased closeness to people who are in their families, a recognition of their limits, but also a recognition of their potential. And I don't think we as a group are thinking enough about how to make what's best in people. So let's look at the take-home message here. The first one I think we want to recognize is that patients and families are the central workers in TM. And you all need to give yourselves credit for that. Those of us who do this work, if you will, part-time, need to give you all credit for this. And you need to make sure that other people are giving you credit for it. That the team of people you have around you should be supporting you in the work that you are doing. Not just the work of curing the problem, but doing the work that you need to do as a person with TM. And I think finally we need to broaden the goals of medical care from just a focus on cure to a focus on helping people be what they can be. Is anybody, I don't know if you all have seen, this particular author, John Callahan. He's a fellow who lives in Seattle, Washington, who had a spinal cord injury when he was 16 years old. Ran his VW bug up a into a quarry. He was totally drunk at the time, which he totally admits, and as he freely admits, was a recovering alcoholic drug abuser for many, many years. But he is a cartoonist now, and he makes these little drawings here. And I put this up here because he published these journals and gets a lot of email from people saying, how come you're making fun of people with disability? What's wrong with you? You're a sick person. Of course, they don't know he's a C4 quadriplegic. They don't know this, of course, about him. But what he challenges us constantly to look at is, what is normal? I mean, what is it that makes a person truly a person? And it's not how many limbs you have in this particular planet situation, or what limbs are working, or how fast you can cover from here to the door. That's not what makes us people. And that, I think, what we need to recognize when we're doing the work of TM, we need to work on making people whole, as we see them on our particular planet anyway. But we also need to help them be the best they can be. Thank you very much.